I'm 52. My name is patient Nemes. I'm coming up from TCC. I have a right portacath. I'm on dialysis. I was found hypoglycemic in the morning, possibly with a fall, which is the reason why EMS put me in a seat collar, and I have a little abrasion. I'm initially with it with normal vital signs, but during my ED stay, I start getting a little agitated and more altered. My family member is with me, and he's not able to really bring me back, and neither is the rest of the staff. I get more and more agitated as I'm sitting in the ED waiting for the doctors to poke and prod at me and get some blood work. I tried to get out of the bed as I'm not really with it. I syncopize, help back on the bed. At that point, my vital signs sounded like they were getting progressively worse, heart rate going up and blood pressure going up. They were concerned about sepsis, possibly seizures, low glucose. They tried to give me a bunch of sugar through the vein to get me back, but it sounded like they eventually thought I was too unstable, so they sedated me, intubated me. I guess I coded at a certain point. CPR was initiated on me, and they were able to bring me back after 1 shock and 2 rounds of CPR. They were concerned about my potassium being very high, being on dialysis 2 days ago, so they gave me some calcium and some treatment for that. Sounded like they were trying to talk to renal and NICU, and then shift change happened, so.
So we brought in a patient, Miss Nemes. She's like a 52-year-old female coming in from TCC. History of end-stage renal, diabetes, hypertension, portacath in the right arm. I think a history of admits for some bacteremia, was found down and had a low sugar in the field, torqued up a little on the way over here after getting some sugar. And then when she was here, started to get progressively agitated. Actually went into VTAC. We had to shock her, got her back. She's also, I guess, 2 days ago was her last dialysis, so the lead there was that she was hyper K. EKG wasn't like so specific, but as we have it now, we called renal. I think we're going to get her a head CT as well for some history of seizures in the past, and she is more stable now in response. I think vitals are now normal. So the only thing to do is follow up with renal, follow up on that CT of the head.
Great. So this lady, she's an elderly female, brought in the EMS after being found down. I'm not familiar with her last name. Her patient's family, typical baseline is completely functional. She was found to have a bruise on the right cheek here, physical exam, otherwise unremarkable. Observed disease here in the ER. Ultimately went to the TAC, lost pulses, was shocked with administration of calcium, got ROS. Subsequently had CTs pending, found to be hyperkalemic. Sugars were low, given dextrose here in the ER. Otherwise, she has a lot of tenderness on her C-spine, so I'm probably we're going to scan that as well. Some additional background on this patient: she's end-stage renal, last dialyzed 2 days ago. History of CVA. History. I jotted down her arthritis, so I'll just give that to you. Otherwise, does have a seizure disorder. History of CHF. Has had a subarachnoid in the past and is diabetic. Further medication probably includes DIG. Probably most likely the pulmonary this condition.
Okay.
ICU's been paged. I've been reports from that.
With whatever right here.
Okay.
So yeah, basically this lady, she came in, she's from TCC, and the sign that we got from EMS was that her sugar was low, she was altered, they gave her some, and she perked right up. She came in, was super agitated, and then kind of fell down, had a seizure, and intubated her. In terms of her past medical history, it's relevant. She's end-stage renal and dialysis, and her last dialysis sounds like was 3 days ago, and she's due for it today, missed. BNP was super high, she had pretty bad breath sounds, so we had initially tried to pre-treat with BiPAP, but then we just ended up having to intubate her. We're not sure we know why her sugar went low. We didn't get any good on that, so we gave her some extra AMCP50 because it was still persistently low here, it was 36. And then her K was high at 5.8, so we did treat her with potassium and then insulin as well. So the sugar is just something you gotta watch out for. Let me think what else. Again, just think about why is this happening. We're not sure. We were initially cooking sepsis when she came in, but she's older at TCC, so we covered her with cefepime and azithral and condamycin. She's really to prevent fungi. We didn't do that. We didn't really have a source yet. Let me think what else. We are concerned that there could be something going on in the head, so she does need a CT head and C-spine. It wasn't really clear in her neck clinically, and it's unclear how she was down, so we just kept her in the C-collar and we're going to scan it. She definitely could have a bleed too. So, like I said, this is really early. We're not sure what's going on. We're kind of doing a bunch of things. She's on humidity, so definitely, she may not have had a bleed before, but we don't know if she may have had it, she may have one now. I think that's everything. Her vitals have been fine. Huge thing, she did code. She went to a VTAC arrest, but she came back with one shot. So that was one thing I forgot to tell you. All right, do you have any questions?
Yep, that's it. 7 o'clock.
Okay. Ready?
Yep.
Alright, so we have an elderly lady that came in after being found down from TCC on unknown length of downtime. Initially, EMS and she was hypoglycemic. Her vital signs kind of gave a picture of sepsis. She came in a little bit altered. Pressure was okay. Rest of her vitals were okay. When she got here, still more combative, got up, basically became altered, fell, unclear she hit her head, which is a mark in her face, so we're not sure if there's a previous injury. At that point, we got her back in the bed, she became unresponsive, went to VTAC, we treated the VTAC, we treated her hyper-K. The labs were positive for basically a high BNP, hyperkalemia. We don't know her DIG level yet, she's on DIG as a renal dialysis patient, last dialysis 2 days ago. So basically where we're at, she just got intubated, but she was not confirmed. The renal's aware, the ICUs are not aware, because we don't know where she's going yet. Her pressures are fine, her bells are fine, she probably needs more access, she can probably use central line at this point. We don't know if she can fidget bond, but she does need a head CT, a neck CT, and a tune confirmation. A repeat EKG after the VTAC arrest would be also helpful because we're not sure why that happened. We started her on ANEO. She's gotten coverage for sepsis, broad coverage. She has no bank allergies, so we gave her cefepime, Clinda, and Azithro. And as far as we know, she's stable. So, questions?
This is an elderly lady brought to us by EMS for an alternating size and hypoglycemia from her nursing home this morning. In ED, she was hypoglycemic, she was altered at 36. We did start G5W during the course of our time with her. She became progressively altered, and she ultimately became obtunded. Her lab showed hyperkalemia. She did go into cardiac arrest requiring chest compressions. Started on an amiodarone drip. I didn't see all of her labs, but I know her lactate was also high. In terms of medical history, she's end-stage renal disease, she's on hemodialysis, she has CHF, she's on digoxin, she has hypertension, previous CDA. She is on Coumadin as well for AFib. So we were worried about, we weren't sure why she was that altered. She seemed to do better when her sugars improved, but it didn't resolve. We were worried about a possible head bleed. We ordered a DIG level, which did not come back. We intubated her ultimately because she continued to deteriorate. At one point, she got up off the bed and collapsed on the floor. So pending is a CT of her head to see if there's a bleed. We certainly worried about sepsis, so we have to follow up on cultures and other lab work. And we started on cefepime in case she has septic. Because of multiple allergies that she had. I think that's about it.
That's it.
Okay.